reference to this component of pharmacokinetics. But before we get into this, I have a couple of questions about yesterday's lecture, and then you guys have plenty of time to study for all of this. First question is, what tissues or organs are found in the peripheral compartment as it relates to drug distribution modeling? You guys remember the central compartments? What organs? Lungs, yes. What else? Heart, yeah. Kidneys, yeah. Liver, yeah. Okay, perfect. What about the peripheral compartments? Everything else. Yeah, that's true. That's true. But specifically, the brain, yeah, the brain. What else? Muscles and fat, right? Right? Correct. All right. Next question. What is the significance of a drug's pKa? What does it tell us? What does it mean? Yes?
How the affinity for a drug to give up goes on.
Absolutely correct. So it is a measure of how readily a drug or compound donates a hydrogen ion proton. It's a variable in the Henderson-Hasselbalch equation. And so when we have a low pKa, that means we're dealing with an acid, strong acid. High pKa, we're dealing with a base. All right. Now, what is the state of ionization for an acidic drug if the pH is lower than the pKa? Loudly, somebody?
Uncharged.
Uncharged. Any questions about these questions? Make sense? Yeah, I remembered all these answers. I'm impressed. All right, so now we're going to start talking about the last component of pharmacokinetics, which is elimination. The kidneys are the primary site of elimination where drugs are excreted in the urine, but also drugs can be excreted through sweat and skin, the lungs, and the feces as well. And so when drugs are excreted in the kidneys, they can be reabsorbed if the drugs are uncharged and lipophilic. If the drugs are charged by making the blood more alkaline or acidic, that will result in the opposite drug being charged, and that will be excreted in the urine because it cannot be reabsorbed because it's charged, and that is called ion trap. So, drug elimination by the kidneys involves filtration at the glomerulus and secretion at the proximal tubule here. Active transport will draw drugs into the proximal tubule, and then the distal tubule reabsorption can occur for those lipophilic and uncharged drugs back into the blood circulation. So, a drug's clearance is a measure that describes how efficiently a drug is removed from the body, and it's crucial for determining a drug's dosing regimen and a drug's half-life. So there are three mechanisms of clearance. We have hepatic transformation, biliary, and renal clearance. Does anybody want to tell me what they think hepatic transformation is? Yes. Correct. Phase 1 and phase 2 metabolism are hepatic transformation. All right. And so A drug clearance is a summation of all the elimination pathways. So systemic clearance is renal clearance plus hepatic clearance plus clearance from any other organs. Clearance is determined, or a drug's clearance is based on the blood flow Q. You don't have to know this equation, but this is just telling you the blood flow to an organ, the amount of drug going into the organ versus the amount going out will tell us the clearance of a drug from that particular organ. And so again, clearance is an additive process of clearance from basically all the organs that a drug can go to. And so we use glomerular filtration rate and creatinine levels to both to assess the function of our kidneys and to understand how clearance works. GFR measures how well kidneys filter blood, and creatinine is a muscle byproduct that is excreted. So when we want to assess our kidney function, we will take the serum creatinine levels, and that helps us determine how well our kidneys are working. You guys will learn much more about this in Farm 1. I believe there's an equation that goes along with this concept that you guys will spend some time to talk about different drugs and how they affect creatinine clearance. So a drug's half-life is the time necessary for drug concentration to decrease by 50%. Remember, half-life occurs for drugs that follow first-order kinetics. Half-life depends on a drug's clearance and a drug's volume of distribution, in addition to other factors that we talked about yesterday: age, nutrition, things like that, and innate properties of that drug. So, if we take the example ibuprofen, which has a half-life of 2 hours, we look at this table below. At time 0, the plasma concentration is 800 milligrams. Every half-life, which is 2 hours, the drug will be decreased by half until more than 95% of the drug is removed after 5 half-lives. So the general estimation or general rule of thumb is that a drug is cleared after 5 half-lives. And so that applies to one single oral administration of a drug. So if you administer a drug one time orally, it'll take 5 half-lives to clear that from the body. It also applies to continuous IV infusion or continuous administration of a drug. It takes 5 half-life for the drug to reach steady state, and steady state is the amount of drug that's entering systemic circulation is equivalent to the amount that's being cleared or eliminated from the body. So if it takes 5 half-lives for ibuprofen at the bottom to be cleared from our body, we would take the half-life times 5 to get 10 hours. And so that means it would take 10 hours for the drug to be removed from our body, or if we're giving that drug continuously, it will take 10 hours for the drug to reach steady state. Any questions about that? So here's another question. You guys may see something similar to this somewhere in the near future. But if a drug which exhibits first order kinetics has a half-life of 7 hours, how long will it take for that drug to reach steady state if the infusion rate is 30 milligrams per hour? Again, 5 half-lives times a drug's half-life, which is 7 in this case, equals 35 hours for that drug to reach steady state. All right? So if we look at a single oral dose of 1,000 milligrams of theophylline, this is used to treat asthma and COPD. We see time on the x-axis, concentration of the drug in the blood on the y-axis. We see after 48 hours, the drug is pretty essentially gone from the body. So what is the estimated half-life? Anybody want to tell me?
8 hours.
8 hours, sure? 9.5, yes. So, close. Very close. So you would take that 48 divided by 5, so 9.5, almost 10 hours for the drug's half-life. Any questions about that? All right, so we have finished pharmacokinetics. Now we're going to talk about pharmacodynamics, and that is what the drug is doing to the body. So now that the drug has reached the site of action, it's active, what is going to happen? So in pharmacodynamics, you have the pharmacological response. What would the pharmacological response be for a drug? Say again? Yes. And what is another name for what that is called, that process when a drug is acting on the regulator? It's on the first slide, the definition slide. What's the name of the pharmacological response that, so we got the example that aspirin inhibiting COX enzyme, that's what the pharmacological response, what is that called? The mechanism of, I'm sorry, I'm not asking a question, so not that, but it's the mechanism of action. So the biological effect or the pharmacological response is the mechanism of action. And if we take aspirin, it would be to block cyclooxygenase 1 enzyme, all right? But what about the clinical response? What is that?
Therapeutic effects.
The therapeutic effect. So in this case, it would be pain relief, as the picture is shown on your bottom right. So you have the biological effect, which is, or the pharmacological response is the mechanism of action. And then the clinical response is the therapeutic effect, pain relief. And so, of course, the efficacy of the drug means that how well is the drug working, and of course, if we consume too much of the drug, we can get toxic effects. And so we'll talk more about efficacy in future slides. But this is putting pharmacology together from the dose of the drug at whatever site it is administered, through whatever site it is administered, all the way to its efficacy and it producing the intended therapeutic effect. Are there any questions how these work together? All right. So, what makes a drug an effective drug? Well, that's based on the efficacy of a drug. So there's some assumptions that can be made when looking at a drug's efficacy. Efficacy is the ability of a drug to produce the intended clinical therapeutic effect. And so when we look at a drug's action, we look at its potency. That is the amount of drug needed to produce therapeutic effect, and the efficacy is the effect of the drug. And so if we're looking at more than one drug, we compare the potency by looking at a drug's EC50. And so clinically speaking, a drug's efficacy is more important than a drug's potency. And here's how all of that comes together. You see the graph, the concentration response curve. This is a semi-log scale, so you have the sigmoidal curves. When we look at drug concentration on the y-axis and percent response on the left axis, Emax is the maximum efficacy of a drug, and EC50 here, that's the concentration of the drug that produces 50% of maximal response. So when we look at this graph, we see the efficacy is the same for all drugs A, B, C, D. However, the potency increases as you go to the left. So drug A is more potent than drug B, and C, and then D. So when we look at a drug's effect, we don't look so much at potency, we look at the efficacy. That's what we want in clinical medicine. And this is the same concept from the last slide, just showing you that sometimes you'll see a sigmoidal curve here or a linear curve. Same principle. Drug A is more potent than drug B, but their efficacy is the same. All right, so we talked about a little bit about therapeutic index when I mentioned drugs that are highly protein bound. The reason why we need to monitor drugs that are highly protein bound is that if they have a low therapeutic window, whenever the drug is released from the protein, the concentration of the drug in the blood may change. Even if it changes a little bit, it could adversely affect the patient. And this is the reason why. It's based on the therapeutic index. So if you look at this graph at the top, warfarin is an example of a drug that has a low therapeutic index. And this index is a quantitative measure of the drug's safety profile. So it's the ratio between a drug's toxic or lethal dose versus the drug's effective dose. So when we look at drugs with low therapeutic index, that means that there's a small change in concentration of the drug that goes from producing the intended effect versus toxic or lethal effect. So drugs that have a low therapeutic index or a small therapeutic window need to be monitored regularly. You will, if you prescribe your patients warfarin or another drug, Phenytoin, there's several other drugs that have low therapeutic index. They will have to get their blood drawn regularly, and you will have to monitor the drug, and that's going to measure their compliance to make sure they're taking the drug and taking it correctly, because you don't want the drug to jump the amount of their blood to jump, and then it will have adverse effects, because these drugs are known for that. And so the example on the bottom, penicillin, you see that there is a wide or high therapeutic index, wide therapeutic window, and that means that you can increase the concentration of the drug significantly in the blood, and the drug is safe. So there's a wide range of the beneficial effects versus when the drug starts to be toxic in 50% of the people or the population. So any questions about this concept? Makes sense? So, in pharmacodynamics, drugs primarily act on receptors. We've talked about the GPCR receptor, and now we're going to talk about a couple of others: receptor tyrosine kinase, Janus kinase signal transduction and activation of transcription, JAK-STAT receptors, and ligand-gated ion channels. So, when we look at receptors, we know that hormones and neurotransmitters are the endogenous ligands that act on receptors. Shown here, a drug that is producing a similar effect as an endogenous molecule is an agonist. A drug that blocks the effect of, or blocks the function of that receptor is an antagonist. So we have partial agonist, antagonist, and inverse agonist. And looking at this graph, drug concentration x-axis, response on y-axis. Full agonist gives maximal efficacy. Partial agonist, the efficacy is reduced. Neutral agonist blocks the effects of an agonist, and then an inverse agonist has the opposite effect of a full agonist and that is due to downregulation of receptors triggered by giving the inverse agonist to the system. So that inverse agonist is going to make the amount of receptors decrease to an amount less than what was basally found in whatever region of the body these receptors were at. So here is a picture looking at all of the different ways drugs can act on receptors. So they can be agonists, antagonists act in the same place as agonists. You can have allosteric modulators, either those that antagonize or activate the effect. And then you can have drugs that act intracellularly and they alter the signal transduction pathway. Questions? All right. So we have competitive antagonists, and these reversibly bind to the same site as the agonist, preventing the agonist from binding. So they reduce the potency of the agonist, but efficacy is unchanged. This graph is showing agonist alone, and then competitive agonist, agonist and competitive antagonists. Does this remind you of something that we talked about in Block 1?
Competitive inhibitors.
Competitive inhibitors, so it's the same exact concept. The verbiage is changed. Instead of Emax, Bmax, AM is EC50, so it's the same exact concept that you guys learned in Block 1. Does that make sense? All right. Non-competitive antagonists act on the site different than the agonists. They irreversibly bind. Aspirin on COX-1 enzymes are an example, and here is what it looks like. So it reduces the efficacy of the antagonist, reduces the efficacy of the agonist, and that's the same concept as a non-competitive inhibitor that we saw with the Katie's medicine graphs. Does that make sense? So this should be familiar to you guys, right? Good. So this is just the G protein couple receptor that we talked about earlier on in biochemistry. And so drugs act on G protein couple receptors through these coupled receptors here for G sub S, G sub I, G sub Q. Does anybody want to walk me through how G sub S pathway works? No?
So your respiratory ligand is an enzyme for non-pharmacological receptors. It's the stimulatory receptor alpha subunit associates with beta gamma subunits, which then stimulates internal potential cyclase, which phosphorylates ATPs to the ATP that those protein cascade.
Thank you very much. Yes. So you guys remember this, right? Yeah, good. And we know the inhibitory pathway does the opposite. It's going to block the conversion of ATP to cyclohexane. And so, great, you guys remember this. Protein kinase C, activation of phospholipase C via the alpha subunit, dissociating, converting, or causing the cleavage of PIC2 to DAG and IP3. IP3 leaves the cell membrane to cause calcium release from endoplasmic reticulum that causes the physiological effects. So you guys remember all of this, and that's great. So now we have receptor tyrosine kinase signaling pathway. Now, there are a lot of steps. I do not want you guys to remember the steps in detail. There's a lot of phosphorylation. There's a lot of phosphorylation at the tyrosine residues that I want you guys to focus on. So we see here insulin is one of the agonists or endogenous molecules that activates RTK receptors. And so in this case, we see that it's causing the insertion of LEP4, which will cause the intake of glucose. So this pathway is involved in cell growth, differentiation, metabolism, and apoptosis. So what I want you guys to take from this pathway is just knowing generally what substrates are involved in this pathway. So there's a lot of substrates. Knowing the full names of the substrates, you don't need to know every phosphorylation step, but you can see the steps are numbered and they're found on the next slide. I don't want you to sit and remember all of these steps. Because remember, there's probably not going to be a lot of questions on the exam about this. Right? Does that make sense? Any questions about what I want you guys to know about this? Anybody? Yes.
So if I was going to condense this pathway for studying to commit to memory and learn, I would probably want to focus on the first step, correct, sir?
The first step and
then would I be so bold as to suggest perhaps the 9 and 10 steps as well?
more than knowing the steps, I would focus on knowing the names of the substrates involved and that they are involved in this pathway. Does that make sense? Does it?
I think so.
You think so? Hey, if you have questions, you know where to find me. But please do not study this and tell me, hey, I memorized this whole thing. I don't want you guys to. I can't say waste your time. I'm gonna say waste your time. Don't do it, okay? All right. Here are the steps, but again, you can read it one time and know the different. So, for example, what is AKT? Protein kinase speed. Hey, okay. The JAK-STAT pathway, again, it's another pathway that has kinase that's phosphorylating tyrosine residues. This pathway is involved in immune regulation, cell growth, and differentiation as well, inflammation. What I want you guys to take from this pathway is what molecules bind as ligands. And there's a hint. Any questions? So, TINs and TERs, interferons and interleukins, you guys probably know better than I do. Have you guys learned about this? Yeah. Yes? Yeah, so you know, so they're involved in inflammation and cell getting viruses and stuff off the body. And then the TINs are involved in blood cell growth. Prolactin, of course, we know that is milk formation, and then leptin deals with our bodies sensing that we're full and fat cells. So again, pathway involved overall immune function, cell growth, and inflammation. Any questions? So what are the ligand? Oh, sorry. Go ahead.
So what is the whole tins and ters like? Just which one's an inter and which one's a
So that's just a shortened, condensed. So we know that these are all ended tin and these have ter in it. So these are the just way to remember the ligands that bind to these receptors. So what ligands bind to JAK-STAT? Any questions? What is this pathway involved in? Great. Any questions?
Wait.
Make sense? Oh, sorry. Go
No,
ahead.
what was it again?
I asked what is this pathway involved in? Like, what is the function of this pathway?
Cell growth.
Right. Makes sense? So, ligand-gated ion channels play a critical role in the fast synaptic activation of the nervous system, and they allow for ions to pass through across the cell membranes to, in this case, hyperpolarize the cell membrane. GABA receptors are one example of ligand-gated ion channels. GABA receptors are composed of 5 transmembrane subunits, 2 alpha, 2 beta, 1 gamma. GABA, the neurotransmitter, binds at the interface between alpha and beta, causing the influx of chloride to hyperpolarize the cell. Benzodiazepines are modulators of GABA receptors, and they bind to the gamma subunit. And flumazenil is an allosteric inhibitor of benzodiazepines. It also acts on the gamma subunit at a different site than the benzodiazepines. And so there are 3 types of GABA receptors. You have A, B, C. And GABA B is a G protein coupled receptor. And these receptors are found throughout the central nervous system, and hippocampus, thalamus, hypothalamus, and other areas as well. And so, as I mentioned before, these receptor systems are involved in they cause hyperpolarization, and they're the major receptor system involved in the inhibitory response by the central nervous system. All right, any questions about the receptor systems? All right, so now we're going to move to a couple of calculations. So when you guys take Form 1 and 2, you're probably going to have at least 3 calculations on each exam. So be prepared to take these 3 conversion factors. You may see these on the exam, so please commit these to memory. And so if we have a question, or if you guys have a question that asks a PA's ordering prescribed dose of 0.15 milligrams of Synthroid. Synthroid is the synthetic T4. If the tablet contains 75 micrograms of Synthroid, how many tablets are required? So you see that there's 2 different units of measure, so you're going to have to get the same units of measure. And so since the product is in micrograms, you're going to want to convert your dose to micrograms. So when you do that, you come up with 2 tablets as the prescribed dosage, and that is equal to 0.150 milligrams. Any questions about this calculation? So, in this calculation, we're looking at drops per minute for a piggyback IV of ondansetron, so 4 milligrams and 50 milliliters to run over 5 minutes with a tubing drip factor of 15. So you want to know how many drops per minute you will see, or you will set, the IV infusion control to. The equation for drops per minute is equal to total infusion of volume times drip factor over total time of infusion in minutes. So if you guys see a question like this, there may be some more variables in it. Don't let that confuse you. Use the variables that are required for the calculation. And so again, drops per minute, GTT over minute is equal to total infusion volume, which is 50 milliliters, times drip factor, 15, all over 5 minutes. So the drops per minute would be 150 drops per minute. Any questions? So now we're going to talk a little bit about the drugs. You guys will learn these extensively. Me talking about them in this course is just to introduce you to the nomenclature. There's a lot of names. Some of them hard. They look weird. They're hard to pronounce. You guys have listened to me struggle pronouncing every single thing that we talked about in this class, and the drugs don't make it any better. So we wanted to introduce you guys to the drugs, and you will learn all the details, probably more than you want to know about in the next few semesters in psychology. And so there are two approaches on how drugs are classified. They're classified by drug class, that's meaning what the drug is doing. They're also classified by the body systems as well. You may see them arranged in both ways, but both perspectives will help you understand what's going on in the body and what the drug is doing. So they're important in understanding the drug's mechanism of action. So we're going to talk about a couple of different drug classes and some examples of each. I've made summary slides that you guys, I would recommend you focus on when studying. They have all the information that may appear on the exam or maybe not. But we're going to talk about anticonvulsants and antidepressants. There are a whole bunch more that you guys will learn about. But anticonvulsants, they treat seizures, either partial seizures, which happen, they're localized to certain parts of the brain, or generalized seizures that happen both hemispheres of the brain. So the drugs that treat partial and generalized are carbamazepine, phenytoin, valproic acid. Then you have some adjuncts, which are gabapentin, lamotrigine, topiramate. And then for status epilepticus, which is a severe seizure where the person's entire body is experiencing a seizure, you would use benzodiazepines, diazepam, lorazepam, and then phenobarbital. So for antidepressants, of course, they treat depression, and there are 4 main classes. I forgot to mention this when I started this lecture, but I finished my PhD. Actually, my PhD is in pharmacology, and I finished my PhD in 2007. Since I finished, there's like 6,000 to 10,000 new drugs that have been discovered, and that JAK-STAT and RTK pathways, we didn't know about that when I was in school. That's how old I am. So we didn't even study those pathways. So that just shows you how exponentially fast the medicine moves. So when you guys start practicing, from the time you start till midway in your career, there's going to be a whole bunch of new drugs, maybe even new pathways that you guys will have to learn about. But of course, it will be much easier because you're not doing it with 7 other classes. You're learning one pathway at a time. But yeah, I was shocked to find out that many drugs have been made or discovered since I completed my graduate studies. And so when I was in graduate school, the selective serotonin reuptake inhibitors they were new, and these drugs, you will learn more details about them, but these drugs, how they're arranged, SSRIs, SNRIs, they're going in order of how they're prescribed typically. So The latter two, the monoamine oxidase inhibitors and the TCAs, those have more side effects, and those were discovered in like the 40s and 50s. Those aren't used that much unless you have a patient that's non-compliant to some of the newer ones. The newer ones have a better side effect profile, meaning they have less side effects. And so some examples of selective serotonin reuptake inhibitors are fluoxetine, and sertraline. Then you have the serotonin and norepinephrine reuptake inhibitors, SNRIs. Then venlafaxine, duloxetine, and desvenlafaxine. And then, again, you probably won't prescribe, if you're prescribing these at all, probably won't prescribe the MAOs, which include isocarboxazid and selegiline, and the TCAs, amitriptyline, imipramine, and nortriptyline. Also, these drugs are used off-label, and I believe you're going to learn a lot about that in pharmacology through Nature Heart. These drugs are used for migraines and smoking cessation. So, oftentimes, drugs, are made for one purpose, and then they find sometimes accidentally that they treat other things, and so sometimes they're used off-label is what they call it. Then another drug class, anxiolytics. These drugs treat anxiety, and they include the antidepressant drugs that we talked about, benzodiazepines, sedative hypnotics, and beta blockers. Beta blockers lower your blood pressure. And here are examples of each of these different classes of drugs. Questions? The final drug is the diuretics, and of course they're used for hypertension. And these drugs act on different parts of the kidney. So you have the thiazides, the loop diuretics, and the potassium-sparing diuretics. And so here is a table with all of that information. So when you guys are studying, I would recommend focusing on this. Any questions about all of those drugs?
So
Yes.
for us studying, this is our first take of just trying to memorize all of these and saying all of these are antidepressants, and then all of
Yes.
these are.
Yeah, just to get you guys to, it might seem like it's like intentional infliction of pain, but it's not, because you guys are going to be learning so many drugs. We just want to get you to practice them, seeing them, grouping them however it works for you guys, mnemonics or whatever might be beneficial. So we wanted to like give these guys a start. Does that make sense? Was there another question? So, because you guys, oh, yes.
On the previous, where it's just like SSRIs for the anxiety medications, is that just all the ones that are used in Amsterdam?
Yeah. Thank you. Any other questions? So, because you guys will be prescribing drugs, it's important that you understand historical factors of how drugs are classified and scheduled, and this is through the Controlled Substance Act of 1970. This is a federal regulation that regulates the use, distribution, and manufacture of drugs. And so it's based on a drug's abuse potential primarily. So there are 5 different schedules. The Schedule 1, these drugs are very dangerous, and they have high abuse potential and no medicinal value, although we know that marijuana is now prescribed. Typically, Schedule ones are not prescribed by physicians, they're used in research settings, with the exception of marijuana. So some of you guys will probably be practicing, and on the civilian side, depending on if you're reserved, or even if you twilight and practice, but you know, in, the DOD, we can't prescribe, marijuana or anything. Schedule 2, these drugs have accepted medical value, but they're severely restricted because they do also have a high abuse potential. And so some examples include morphine, methylphenidate, methamphetamine was one that we can prescribe now, but that wasn't always the case. And Schedule 3, these are less habit forming than Schedule 1 and 2, and they may lead to moderate or low dependence. And so they include ketamine, the anabolic steroids, and some codeine formulations with APAP Tylenol. Schedule 4, these have low abuse potential. They include benzodiazepines. This profoxafen, it was removed from the market. It is an opioid. There's some issues with it affecting heart, causing heart issues, so it was removed from the market. And then you have some other ones. These drugs are used they're used temporarily. This is a muscle relaxant, and of course, this is used for weight loss in combination with diet and exercise. But overall, relative to the other schedules, these have significantly lower abuse potential. And then Schedule 5, very low abuse potential, and they primarily include cough syrups with less than 200 milligrams per milliliter of codeine, and also some other drugs like pregabalin and some drugs used to treat diarrhea. So here is a table summary of the definition or description of each schedule and some of the drugs that are found in the schedule. Any questions about the CSA drugs?
That one says now prescribable for methamphetamine.
Yeah.
Awesome.
All right, any questions? This is the actual testable information. Do you guys have any questions? All right, so I just wanted to end this lecture with some study tips. These are taken from slides from Major Hart's, who is the pharmacology professor, taken from her slides. She will be going over most of this information with you guys next semester. But I just wanted to, show this to you so you can be thinking about maybe how you want to frame, how you prepare your study materials for this class. So there'll be about 3 calculations on each exam. You will not be required to know the brand name of a drug, only the generic. So dosing is not necessary only under certain situations. And you will not be diagnosing a patient's condition in pharmacology, but you will be determining what line of treatment is best for them. And you are not expected to know the normal lab ranges for any condition. So she recommends that for each disease condition, you have your drug classes, you include the mechanism of action, the adverse effects, the contraindications, and the drug-drug interactions for each of the drug classes, each of the drug that you guys learn. And of course you guys can talk to the other classes, but most of them I've seen, they create Excel sheets with all this information, and it helps them organize it and put it together. This class is considered a tough class, but you guys will do very well. You've done extremely well So don't ignore me in the hallway next semester. I'm gonna give part of the speech again at the end of class, but yeah, I'm here for you guys. Again, if you have any questions about anything about BIOCHEM or researching about Office 1319, and email me via Canvas, and we will be having the review for this exam. When is the review again? Next Friday. Next Friday. So I will see you guys. If I don't see you before, I'm still on this Friday. Okay? Any questions?